Awesome. Thank you. So Charlie always assigns the talks, and he always makes me give the lateral talk every year. I try to get out of it. You saw he took the artificial disc one. So it's great to see everyone, and great to I can't believe we've been doing this for 15 years. So I'm going to talk about lateral, and I'm a little conflicted, especially now that I had my knee done from a lateral approach. So I think most of the orthopedic surgeons can see this. I had a tibial plateau fracture on my left leg, and so fortunately this all healed nicely, and I'm almost about 85%, so not 100% yet, but I'm doing well. And it's interesting, we talk about artificial disc, we talk about robotic surgery. There's so many cool approaches, and there's so many different ways to tackle the spine. And I always think, these newer approaches, it's kind of fun, right? Here you have, I've learned a lot from these courses. I've learned a lot from other surgeons. And, for me, lateral was always like, how can you do something that's like minimally invasive? And how can you, get access to disc space? And there's so many different things that lateral can do for you. As Dr. Chapman said earlier, when you're building your practice, you want to get good at doing something. So when I was finishing my residency in Virginia, I knew I had to come back to Seattle and compete with Jens Chapman, who was the big fish in town, and he was at Harborview. And I remember when I was a med student, I rotated with Pat Johnson and Jens. And Jens had this awesome service where it was ortho and neuro combined, and it was actually one of the only ones around the country where it was truly combined. And I remember all the neurosurgery residents at Harborview, they loved their year with Jens because they just never had that orthopedic influence. And I've learned a lot from working with orthopedic surgeons and working with Jens, Amir Abdul-Jabbar, and getting to know a lot of the faculty here, David Skaggs. You surround yourself with smarter people, and then you'll become a better surgeon. It's like osmosis. And so for me, lateral was that, how can I do something that's cool, it's minimally invasive, and patients can have a quicker recovery. The only problem was, it was a new procedure. They didn't even have codes. And then here, we're supposed to access the retroperitoneal space, which again, as a neurosurgery resident or orthopedic resident, you're like, what the hell is that? Who goes? The only time that I got in a retroperitoneal space is when I screwed up a distal end of a shunt. You're like, you see it all, tangled, and you realize, okay, that's where the retroperitoneal space is. But the urologists know it, right? They do Da Vinci robot, they do all these cool procedures, and I just, I thought this was a great image, but nobody gets into the space. And sure enough, as a resident, we have all these. This is an old Gray's Anatomy textbook. Like, that's not what the retroperitoneal space really looks like. And a lot of the textbooks that we have are older, and they really didn't. I was like, God, there's nothing to read about this procedure that people keep talking about. It's so cool, and I've learned by doing, but also by spending time here at SSF, and we have great fellows. In fact, one of our fellows, Cliff, you'll see just sitting there. This picture of him and Sven, they're eating dumplings. This is a very famous dumpling place in the city. But the point of this is that, what you're taught in residency, med school, a lot of the textbooks, they don't talk about there's nothing in any of these textbooks, right? So I learned with the fellows, doing dissections, doing what you guys are doing coursework. And, when we're in med school, they teach you all this stuff. You memorize it, like the brachial plexus, there's the trunks, the roots, and all the, for the lumbar plexus, there really wasn't much, and so our fellows here, both are have done a lot of work in this, and this has been a passion of mine for the last 15 years. And what's amazing is that there's very little published about the plexus, and but here we're doing all these lateral surgeries. You go to every meeting, everybody's prone, they're upside down, they're doing, prone lateral, lateral prone. I mean, everybody wants to do it, but here they don't even have any. Nobody knows the anatomy that well. And what I found out about the plexus, so this is Jens's cousin. This is a great picture. Everybody, these two guys are related. You can see Jens has a little bit more hair than his cousin. But they look similar, but they're different. The plexus is the same way. No one has the same plexus. And then this is actually one of the figures from one of our books that we ended up publishing. And it was really 15 years of surgery, spending time in the lab, dissections, having every single complication you can think of. Hopefully you guys will not have these complications because you're spending the weekend here to learn about all these great procedures. And again, whenever you're doing lateral surgery, it's really based on fluoro, right? You don't see the whole retroperitoneum. You don't even see the lumbar plexus. So we have very sophisticated neuromonitoring. But again, if I can emphasize one thing, is just surround yourself with very smart people that are experienced. Don't go do crazy surgeries when you're first starting out as an attending. And it's going to courses like this where you learn, you go, hey, what is the, you can dissect out, go after we're done tomorrow, let's dissect out the plexus. I love doing stuff like that. That's how you learn. And again, like I said, I was very fortunate. I'm surrounded by super smart people. This is a great picture. There's Cliff. You have Jens Chapman, Keith Mayo, Alex von Glinsky, and Thomas Schildhauer. And Thomas was one of Jens's fellows, and Keith is one of the godfathers of hip and pelvis. And then Alex did this whole, when he was here, we did all these dissections. And again, all these, there's so much knowledge about this area that I, as a neurosurgeon, I just never was exposed to it. And so we did a lot of dissections. And then this is actually how complicated the plexus looks like. That's a 3D reconstruction. And you can see, here's another picture. We put guide wires in to kind of see, this is actually what it looks like. If you were to light up the plexus, that's what it looks like when you're doing lateral. Raise your hand, who wants to do lateral now, seeing the plexus like that? No one, right? I mean, who on earth? It's like going to see Pat Johnson. This is the LA freeway, Santa Monica, during rush hour. Forget it. You just stay right in Venice Beach. You wouldn't want to go on that. But you surround yourself with super smart people like Julius Gerstmeyer, who's here. He's one of our research fellows, who does a lot of stuff. And again, this is another scary picture. You guys will not want to do lateral after this talk, okay? But this is what the plexus looks like. It doesn't freaking move. Like people talk about, oh, if you position this way, that way, it's going to move like maybe 0.1 millimeters. I mean, this is not going to move. You have to hit the sweet spot, which is the disc, and not injure the nerve, okay? So you can talk about doing all these different positions, but this is what matters. Doesn't matter if you're prone, doesn't matter if you're lateral, prone lateral, sideways. The plexus is what you have to understand the anatomy. And again, even more scarier pictures, right? Nobody wants to do lateral anymore. But you can do it. You got to have a good team. This is the team at SSF, right? You got to have a good team in the OR. You have to understand, let's say if your neuromonitorings go off, maybe you don't do that level that one day. You bail because you can have serious complications. And again, it looks even scarier, right? I mean, look at all these nerves. And these are just some, just learning points that I had. And usually when I do lateral, I'll get a CT, I'll get a lumbar MRI. I mean, you look at all this, you can get a lot of information about, what things look like before you start doing it. And again, I wouldn't start, doing these surgeries where you start doing corpectomies. I wouldn't start at L4-5 when you do your first lateral. I wouldn't start doing these more. I'm going to show you guys some cool cases. Once you feel comfortable, and again, for me, honestly, it's probably like 50 cases. I would not start doing corpectomies. I wouldn't start doing crazy. I'm going to show you guys some crazy cases, but that's 15 years worth of 20 years worth of doing these, right? And like I told you, I've had plexus injury, I've had femoral nerve injury, I've, ureter, bowel, colon, hemothorax, pneumothorax, kidney. I mean, it's all there. And you can, trust me, you can injure. And I've had every single complication you can think of. But again, the key to it is you got to have a good team and you got to understand what you're doing. This is, I thought I would show you, this was a cool picture of me at Harborview after my surgery. All my buddies came and visited me. Jens came over, had great care over there by the trauma surgeons. And, it's humbling when you actually have to have surgery. You realize it really takes a team. Again, just like I was telling you earlier, this is not the case you want to tackle the first time you do lateral, right? This is a case that you want to do later on. It's thoracolumbar junction. Patient came in paraplegic. You can do this posteriorly. Do what you're comfortable doing. Don't take risks the first few years in practice. Do what you're comfortable doing, which is you go posterior, you put in the pedicle screws. You don't have to do a lateral corpectomy, but after you get experience and you feel like you can do it, these are the kind of cases that you can do. This is a picture of one of my old partners, Dave Hanscom, who used to practice here. This was at his retirement party. Instead of working out, he decided to get a suit, and we had a lot of fun with Dave. And Dave was here. This is actually one of his patients that I did a lateral on and then went posterior. This was like a 2-stage procedure. But this is the kind of stuff that you can do once you feel comfortable. And again, like most things in lateral, these are more advanced procedures, right? I'm not showing you the L4-5, L3-4, L2-3. Those are kind of the bread and butter. But the most important thing is understanding the anatomy and understanding what the plexus is, right? So this is an L4 corpectomy I did for a tumor case. You're not going to be doing this in your first 2 years in practice, okay? It's just not going to happen. And but if you understand the anatomy, you understand where the plexus is, you can map it, you can put in. Look how big that cage is. This is true, not to bag on the endoscopic guys like Jay and some of the other people here. But this is real minimally invasive surgery. This patient went home like 2 days after having this procedure. And again, I've got some pictures that I'm going to show you that, they're tiny little incisions. And I got a picture. This is one of Kojo's cases from about a month ago. You can see, who wants to have Kojo operate on you? I wouldn't. Look at that incision. She's going to have, it's called the shark bite incision. She'll have a hernia afterwards. She'll have, intercostal neuralgia. She's a chronic pain patient. And then look at my incision. What would you rather have? The left or the right? So I think, again, another corpectomy I did, actually that was that one patient that I just showed. And I like it for tumor cases, okay? I like it for infections. I don't like doing these, corpectomies for deformity. I don't like it doing, I like it, it works really well for infections and tumor. Like this is a great tumor case that we did. And you can get, look at how much, look at the cages nowadays, and they're getting better and better. You can get a tiny little cage that can expand to like 40, 50 millimeters. And you look at the end plates, the end plates, they're much better than the cages that you can put in posteriorly, right? they're cylindrical and they can subside, they can go through the end plate. And here's another L3 case that I did. You can see, you get very, you can pretty much take out the entire vertebral body. And this is a 2-level corpectomy that we ended up doing. This was an infection case. And again, just like you do posteriorly, you got to take out the back wall. So actually, what this shows you is the retractor placement is key. So typically what I do is I start posterior, work my way anterior, and then decompress the central canal. And then that was the infection case. You can see how much subsidence there was and bone collapse. Here's another tumor case. You can see, the amount of, and again, you can see it there. This is a very challenging case. This is an L4 corpectomy. So, the risk of having a femoral palsy, femoral nerve injury is super high. So you can't take forever. Here's another case that I did that we ended up doing. It was a tumor case. And again, with a lot of the new instrumentation, they have fenestrated screws. So you can put cement and then put your screw in. You can go one level above, one level below. But you also have to be careful. I mean, we've been burned, Jens, right? You can get bad subsidence, fractures. I mean, these can be highly unstable. You definitely, you can definitely have problems. And again, it's one of these things where you really, patient selection is important, and then technique, right? So even though this is L3, you can still have, a femoral nerve injury. And, you have to monitor, and retractor placement, retractor time itself, all these things are important. And I don't know if you guys know this, but Dr. Chapman, when he was a resident, actually was in a band. I think this is during one of their concerts backstage that I was able to get this picture. And we've had some fellows come through from his old residency. So I have a treasure trove now of where Jens had long blonde hair.
Can you send that?
Yeah, I will send it to you. I have a good one too of when he was a resident. It's still up in it. One of my good friends is the chair at UT Southwestern in neurosurgery, Nader Parati, and so I've got all this treasure trove of photos. And again, this is another excellent case. This is Jens looking more serious. He's got his more serious look, a little bit less hair. And we do a lot of these cases together. He'll do the posterior, clean everything out, so I don't have to take the back wall off. I can just go in, drop the cage in, and this is one case that we did together. And you can see, it makes it funner, and the patients do great. And I hope one of the things you guys get from this weekend is we're so privileged to do what we do, right? I mean, it's such a great profession. And part of our fellowship, we spend a lot of time, because you guys come in, everyone's kind of burned out. They're tired of, taking call. I mean, it's like, I kind of sometimes feel like we have to do 6 months of therapy, And the fellows get so whiny, and like today, I mean, I was on call and I did clinic. Where's Nick? Nick and Cameron. Where did Cameron go? So Cameron and Nick are up here. I saw them like, yeah, we're having fun, And then I went to the ER. I saw a consult. I was on the phone. I had to go to the ER, clinic, everything. But just remember. This is a great year. You get to learn a lot, you get to have a lot of fun, and you get to, come to cool courses like this. So you can see Gary, who's our lab guy. I mean, you just have to remember, you have to have the long-term perspective. This is a great profession, and you guys are all going to have great careers. And part of hopefully what you get from this weekend is, just have fun too. It's not all, you don't have to be stressed out. You're done with residency. You guys made it. Yes. Like you've, and fellowship is just one other thing. We always deal with this in our fellowship. It's almost like everybody's trained for delayed gratification, right? You're like, okay, I can't quite celebrate yet because I have to do fellowship. And then you're like, oh, but I don't have like the perfect job yet, so I'm still job hunting. And then you just keep, it's like, don't have the perfect house. I'm like, guys, listen, what you have now, like when you look back, having the big house with a huge mortgage, lawyers chasing you, journalists chasing you, like things get more complicated. Trust me, I've been there. And just enjoy it. Like every day, like it's a new challenge. You learn new stuff. Like even this weekend, you get to do a lot of cool stuff in the lab. We have super smart people here. And again, you get to, eventually you can do something like this, where you do a complete corpectomy, you can see the vertebral body's gone, right? And you get great lordosis. I mean, look at that. These are obviously cases that are more advanced, but I just want you guys to see what's possible. But you got to spend a lot of time. You got to go to courses. I encourage you to, I'm happy to talk to you. You guys can make connections with the people here this weekend. What I've learned, I've learned the hard way. Like I said, there was no textbooks. I remember I learned from Luis. I remember I ran into him like 2001, and I love him. He's a great guy, but, it's like he lives in Brazil. You see him once a year, and then that's it. And then, so you have to learn on your own, and you don't want to make, a lot of mistakes and don't want to have to learn the hard way. So learn the lab, come to courses like this, talk to people, talk to Woody Cross, Pat Johnson. I mean, there's so many people that have been doing this for a long time. Trust me, whatever you guys think is possible, we've had those complications and we've dealt with these patients, And again, these are more complicated cases. A case Jens and I did of a patient who had, had a basically burst fracture. It pseudoed, the cage was going posteriorly, and I was able to take this out. We cut the cage out.
I do want to point out, we did not do this case. This was done elsewhere.
No. We revised it.
Yeah, we revised it. Just want to make sure.
Exactly.
Just want to make sure to avoid.
Yeah.
We live in questioning times, and so this was not done here.
And this was a difficult case, actually, Jens, because you remember, she had the Kojo Hamilton incision. So she had this huge, honest to God, this is what happens, right? You have an access surgeon. This is what they do. You're not in the room, whatever. The guy goes, marks the incision like from here to here, and then, but what do you need access to? Posteriorly. Her incision was way anterior. So here you do this massive incision, and then all you need is that little access. And I remember Jens and I were talking about this case. Jens is like, are you gonna be able to do it? Because she had, I go, absolutely, I'll just go behind it. And we made a tiny little incision, and we were able to drill that cage out. You can see it there. I used a metal cutting burr. The only thing that was crazy is like sparks were flying. Everybody was going crazy because, you can't really, it's in the chest. And so the fellows were like dumping irrigation into the wound. But again, the key to doing, lateral, again, it's basic anatomy, and there's not a lot of stuff out there. But now there are some, there's lots of papers, and this is I'm putting a plug in for my own book. Go buy this book. This is a great book. There's not that much on, and this is 15 years worth of work that we did because there wasn't anything that was out there, And it ended up being, and again, I learned from all you guys, the fellows. This is a team effort, have fun, enjoy this weekend, talk to the faculty here, and I think we could probably have one more demo.
Yes.
and then, enjoy fellowship because it goes fast and there's lots to learn. And like I said earlier, you guys have a great career and a great platform, and all this stuff, technology, AI, robotics, it's only going to get better and better. So thanks again.
Thanks, Rod. Any questions for Rod?
So first of all, disclosure, Rod does all the far laterals because I just do the posterior part, and then he comes in and saves the day. Rod, for corpectomies, but I'm going to challenge you on that. Isn't it smarter to actually just say go into the upper lumbar spine or even the thoracic spine rather than diving around in L4-5 or below, because that's where the real plexus problems happen. That's where the ureter floats around or the colon wafts in.
Yeah.
So stay away from the major deformities and go into the upper lumbar spine. And actually, corpectomies, we showed a paper, this is under peer review right now, T12 corpectomies done in a cadaver in a simulated OR environment by fellows who are adequately trained are perfectly safe.
Yeah, I mean, I think, again, so in terms of thoracolumbar junction can be tricky, though, Jens. I think when I was talking about, like, just understanding the lumbar plexus, definitely, L1, L2, but it's still hard. I mean, like if you've never done one, to start at L1 and then try to do corpectomy, that's not an easy operation. But in terms of the plexus, I think, understanding how, to interpret neuromonitoring, positioning, where do you dilate. When I first started doing lateral, we actually didn't have neuromonitoring. On every single case, I would go down, I had a microscope, I would go fiber by fiber by fiber, and I actually would find the femoral nerve and place my dilator in front of it and retractor in front of it. So the neuromonitoring came later, right? I mean, these things, it sort of evolved. And again, all the companies now have, good monitoring, but I think, Jens, your point's a good one, where I think, for me, being a neurosurgeon, the most devastating injury is the femoral nerve, because you knock that guy out, you just basically like incapacitated the person. It's multiple nerve roots, multiple muscles. So I think starting up higher is probably the way to go.
All right, those are valuable lessons from lots of experience.